Loving salutations to our beloved Bhagwan, Sai Ram to everyone. Have the opportunity to share with you updates of a very recent initiative which started about 3 years ago. We would be completing 3 years of the Sathya Sai Palliative Care Center operations in Puttaparthi. This has been an initiative driven by the alumni from the Sathya Sai University, the Institute of Higher Learning at Prashanthi Nilayam, and run by a foundation set up by the alumni called Swasthyam Palliative Care and Cancer Foundation, and with technical support from a very well-known organization in the palliative care field called the Pain Relief and Palliative Care Society in Hyderabad. So this center is the picture that you see out there is just about 700 meters from here. So when you would like to take a walk sometime in the near future, just you are all welcome to see it. Um, like they say, a picture is worth more than 1,000 words. So more than what you hear from the talk, I think the experience of visiting it would provide a lot more insight. Just to, since palliative care is still a very nascent subject for general public and also to some extent in the medical field, uh, I just would like to set the scope for palliative care, though it's associated with end of life care, terminal care. The genesis of it perhaps was there, but today palliative care as a medical specialty has widened in its scope, and it's recommended from the time of diagnosis of any of these chronic, serious, life-limiting illness. It could be cancer, it could be stroke, it could be organ failure, kidney, heart, liver failure, a lot of congenital neuromuscular disorders, a very wide spectrum of conditions where one is not uh, handling just a one-time episode of various symptoms, but recurring, a very rocking journey that they have to handle. And therefore, palliative care is recommended right from diagnosis stage in these kind of conditions, while the role for curative specialities would be the primary acting role. Uh, it is recommended from inception. As the disease progresses to more serious and progressive and terminal conditions, the role and scope for palliative care would increase, and at end of life, primarily handled by palliative care. And it just does not end with end of life. We continue to engage with the family to handle grief at the end of life, handle any other aspect that within our capacity we can help reduce the shock and the grief that they go through. That's broadly, it's a very wide scope, and its implementation, execution is something again subject to training and resources available. In our current center, an ideal palliative care is what can be delivered as a continuum of care, right from home care to inpatient care, and this bridged well with the tele support. In our current setup, we have two vans, each of which covers about 6 patients a day at their homes, those who need palliative care. And we do this within a 50-kilometer radius from Puttaparthi, which covers all the major towns and about 150 odd villages around Puttaparthi. And there are, and that's complemented with the inpatient facility, a 10-bed facility here, where we offer everything from daycare to long-term care. Uh, it could be 1 month, 3 months. We increasingly see a lot of daycare as well, with an average stay about a week. Uh, just to understand the ideal paradigm of palliative care, conventionally we are used to a pyramidal structure where most of us would have to go to a hospital to handle our medical needs. The scope for daycare, uh, as it is more is possible, but sometimes limited because of insurance not covering a lot of daycare. So you're generally pushed to hospitalization. And home care in conventional paradigm is still a privilege of few, perhaps. On the contrary, it's a funnel that we see in palliative care, where ideally the best place to provide palliative care would be at home. And that's a constant endeavor to push how much we can deliver in home care settings. And only when the situation demands that they have to visit a hospital, within that we try to encourage as much as possible a home care, and very small percentage of that getting into a palliative care center. So what do we handle in palliative care? I like to put it as a shock absorber in a more layman terms. In this journey of a lot of these progressive conditions, one is constantly encounter one shock after the other. Um, a huge burden of symptoms, starting with pain, and often palliative care is associated largely with the cancer because usually the symptom burden is much more severe and much more unpredictable in the journey in cancer. And pain management becomes very central to the whole effort. But it's just not pain, but a lot of other symptoms that you see out there displayed, and a lot of GI symptoms on the right, what you see. All of these need handling, and they come either in sequence or compounded, all of them. And it needs patient handling of each of these symptoms. And in home care, it's not limited to just medical management of these. We are able to manage in home care chronic wounds, whether it is non-healing cancer wounds, or they've developed pressure sores, or some chronic venous ulcers, often very neglected in rural settings. And the home care team is able to provide uh, repeat wound management. Then for GI symptoms, whether they need constipation management, catheterization, feeding tube, lymphedema management. And we are also in whether it's liver cirrhosis patients or cancer with liver mets, they often need recurring ascitic tapping. And we are actually able to go as frequently as somebody might need it twice a week, somebody fortnightly, and do that ascitic tapping. They're already with a lot of symptom burden with very limited mobility, and actually try to get anyone out of them out of their home and getting to a hospital is truly a nightmare for many of them. And colostomy and tracheostomy care, uh, fistula care, and sometimes it's very sad because of poor hygiene conditions. It's just simply lack of understanding of wound management. We see a lot of maggot infestation in some of these wounds, and all of this truly at the comfort of their home, we're able to provide this. And other services on the right, not all of them perhaps possible at home care, but to the extent possible, we do that. Otherwise, at the inpatient center, the physiotherapy services, counseling is very central to palliative care. And of course, palliative care is a very holistic approach, and therefore, there's a need for addressing uh, their mental, emotional health as well. And that's where the role of a lot of other dimensions of care come into picture, whether it's having bhajans for them, music, art therapy, games. So there's a lot of this is supported by volunteer engagement. And of course, central to palliative care is end of life care. And so while we set about doing palliative care, it's a universal need. And I like to put it this way, that when we arrive into the world, we need the support of the pediatricians and gynecologists. But we are not yet there when our life turns frail, and which is a universal reality. And as a society, we have not yet reached a point where we have universal access to palliative care. And I think this is one effort, a small effort, to bring that dimension to the care. And so when, as we were doing this, uh, right now we have about 1,000 plus cancer patients, and we about two-thirds of them are cancer patients in the palliative care. And within that, again, 60% of that are simply breast and cervical cancer. And so we we said, can we do something about early detection? It's not just why should everybody turn up in palliative care? Can we prevent some of them arriving early into palliative care? And that's some effort we should sincerely put behind. And so a year ago, we started that work as well. I would like to quickly walk through. This is some very interesting data of very specific to this region. In fact, just about 50 kilometers, not even the entire Sathya Sai district, because the district spans almost 100 kilometers in its radius. This would be quite unique in terms of data collection, because very often patients are shopping from one hospital to other. It's very challenging to get long-term tracking of cancer data. Uh, However, in palliative care, since we are tracking them long-term, we have some insights into that. In 3 years, both cancer, non-cancer patients, more than 1,000 plus. And specifically, I want to dive into two slides. One about the kind of cancers that we have seen. And this almost mirrors data in many other geographies that a lot of cancer doctors who looked at this data kind of know that it's very similar pattern, and that what gets reflected in here. But what you would notice here is uh, the mortality and the disease burden, and the top among the top five, the GI tract has the most severe symptom crisis. And this has actually helped us to also orient our own palliative care delivery model to be sensitive, to be able to triage who needs palliative care follow very rigorously. Because in our own experience, we would notice that not all patients are vocal. There are some people with a slight prick can get a roof down. That's how sensitive they are to pain. Whereas there are people who are drowning in pain and they don't squeak. So the idea is we should be able to, not just based on the decibel level of how much a patient can reach out or whether they're able to call, but we should be able to follow up by predicting what kind of symptom burden that they can go through. And the next slide, within the GI tract of specific interest to us, we've seen more than 100 odd cases. And it's just to throw open a question, what are factors that could be influencing the incidence of these cancers? One could spend time looking at the age profile and a lot of other parameters and study this. But I'm putting this up just to show that there's a lot more opportunity to do research in this field. Apart from cancer, we also handle non-cancer patients. About a third of our patients are non-cancer patients, primarily stroke patients. And a next segment, larger segment, would be chronic kidney disease. Some of them going through dialysis, some of them unable to afford or simply don't have access to. So that's the profile of the non-cancer patients we have dealt with. And as I mentioned about cancer screening, which comes with support from the Ramaya Hospital, and we have screened about 1,000 people since a year. And the idea was not only limit to what do we do after we screen. One insight we have from the poor outcomes in cancer, if you take even just breast and cervix cancer, is that compared to the Western countries, we still have very poor outcomes, even though we have possibly all the medicines, chemos, and surgical facilities available. Two things. One is very poor late detection, and second, they often do initial effort of first 2 3 months going to the medical facilities getting treated, but then afterwards they give up, they develop fatigue, the family develops fatigue. And one way we can address that is to have more localized centers, so that they don't have to travel far, they don't have to get displaced. With that intent, we said we should be able to funnel some of the early detected uh, people with early intervention in Puttaparthi. So as a part of the larger effort for Swami's 100th birthday celebration, we're hoping to set up this new facility, which will integrate palliative care with early intervention for cancer, including surgery and chemo. That's our little offering to Swami, part of the centenary celebrations. To conclude, to just look through the whole uh, palliative care in a certain perspective, I will lean on this, something that's very culturally connected, rooted to us. Of course, sorry, just before that, uh, All of this requires a lot of team effort, whether it is staff, full-time doctors, nurses, the support staff, a lot of volunteers, visiting doctors, physiotherapists, then volunteers on site, remote volunteers, and a lot of partner institutions. Of course, all of this would not have been possible without continuous support all of these patients have from our super hospital and general hospital here, and also the mobile hospital uh, from in Puttaparthi. So the teamwork is really essential in being able to deliver holistic palliative care, not just the physical aspect, the emotional, social. And thankfully, palliative care is one formal medical specialty that talks about integrating spiritual care. But I've always pondered looking at patients. It's quite easy giving the pill, reducing pain, addressing a lot of symptoms. But how do you so quickly be able to alleviate deeper spiritual questions? You would see patients, very young patients, who've had no other seemingly risk factors, get terminal cancer, young people as young as 20 whom we have seen. And the simple question is, why has this happened to me? I've led as disciplined a life that one could appreciate. And why has this come? So it's perhaps not possible to be able to give it an appeal, but this is something that I think has to come. We have to invest in it in everyday life. And to this, I lean on to a prayer that is almost ancient in our culture. That is, Anayasena Maranam, Vina Dainyena Jivanam, Dehante Tavasayujam, Dehime Parameshwara. It, I think, very succinctly captures what palliative care can deliver. That is, a death without any suffering or pain. And not just why only look at death. Our life also should be as pain free as possible. And that's because a lot of conditions are there. People go through that journey for years together. And can we make that shock free, pain free? And ultimately, a lot of this pain cannot perhaps be handled only with pill. I'll just share with this comparison without taking any patient identity, but I've had the privilege of seeing patients who are perhaps going through such intractable pain, but they're so poised, so pleasant, and they have told our team that I am just, don't come to me. I will just want to do contemplation. I want to do namasmarana, and just I will only call you when pain is distracting me from uh, contemplation. And then only then please come and give. I'm amazed to see that kind of resilience, and perhaps that can never come with a pill, and that's a lifetime work to be able to reach that kind of fortitude. And that's a long journey, and palliative care requires this holistic effort and holistic teamwork. And this is a small initiative, and we hope from here it can go to more people and more places. Thank you, Saira.